Introduction, Sue, and always a pleasure to be with pediatric colleagues and fellows. I wish I had done this in person. I greatly enjoyed my last visit to CHEER, where I did present some years ago. But so much in the world has changed, and so much in the world has changed because of COVID-19. So I'm very happy to share with you some thoughts in relation to how it impacts children and pediatricians working anywhere in the world. But let's start with a traditional faculty disclosure. There are absolutely no commercial affiliations in relation to this presentation. The work that I'm going to share with you was funded by UNICEF, both at headquarters and ROSA, as well as my own core programs. I am a member of the WHO SAGE and STAGE Working Committee on COVID vaccinations, but the thoughts and ideas that I'm presenting to you do not have any bearing on the institutional policies in relation to this. So this is very much my own group's thinking. Well, it's amazing. I was looking at the numbers this morning as to how much has changed since we first heard about the case in Wuhan in China in this late December 2019. So over 254 million cases worldwide, 5 million official deaths, a large proportion in low and middle income countries. Virtually no geography in the world has been spared the impact of this pandemic. And we believe that these data only represent the tip of the iceberg. If you look at the estimated ratio of total COVID-19 deaths to reported COVID-19 deaths, these range from a factor of 5 to 15, 20 in many geographies where there are very poor reporting systems. So it could very well be that the figures for COVID-19 mortality are about threefold higher than what we have. And this could easily parallel what had happened at the turn of the last century with the global flu pandemic. So what am I going to cover over the next 40 minutes or so with you? So we'll start with the spectrum and diversity of the pediatric COVID-19 disease worldwide. I will say a few words about multi-inflammatory syndrome that most pediatricians are quite interested in. I will talk substantively about the indirect effects of COVID-19 because there isn't sufficient discussion within pediatric circles and certainly clinical pediatrics of what could be the more important impact of the illness. I will speak about our work on schools and transmission risk of COVID-19, particularly in the context of how does it impact decisions on mitigation strategies and immunizations, with which I'll close. Now, I couldn't have done all of this myself, of course, and I would like to acknowledge that the work that I'm sharing with you today represents that of a very large group that we set up and that has changed over time. Some people have gone, but we have a multinational group of people working together on COVID-19 all the way from Australia, US, and Africa and Asia, with a significant now number of people from China as well. And I'm very grateful to all of them for various parts of the scholarship that represents what I'm sharing today. So before I go to the pediatric impacts of COVID and what we know, let's start with the mother. So we published this systematic review on data from pregnancy with confirmed COVID-19 infections, and also in some relation to disease severity fairly recently, work led by Zora Lassi from Adelaide and others in my group. And it explored not only the potential mechanisms, but also what we knew about clinical outcomes in relation to COVID-19 infection and pregnancy, maternal outcomes, of course, but also things like prematurity and impacts in the neonatal period. What we did not find, and we have not as yet explored fully, the work that will emerge, is any impact in terms of long-term outcomes from exposure in pregnancy, neurological, and also things that may relate to long COVID. So a large body of evidence, and much of it available from literature and high-income settings. But if you look at the 62 studies that were included in this systematic review, that represents within it around 31,000 cases. And increasingly, the number of reports from low and middle income settings in Africa, Latin America, and Asia is increasing. So to summarize, if you look at outcomes based on COVID-19 severity in about 3,000 cases, there is no question that severe COVID-19 infection in pregnancy is associated with significantly higher proportion of adverse outcomes in the newborn. Neonatal care admissions to ICU, prematurity rates, stillbirths, on which we are only just beginning to get data, and indications for intervention. Now, it's possible that indications for interventions are also clouded by people wanting to do something different. As yet, there is no recommendation for cesarean sections in COVID-19 infections per se, but that represents what's happened since the beginning of last year. Perhaps the most robust data on COVID-19 infections in pregnancy and outcomes are from this large multinational cohort that we set up as part of our intergrowth, interbio, and intercovid multinational studies in a network that I am also a part of. So here, in this work that we published in JAMA last year, we looked at the severity of infection and what we knew about it on the basis of criteria of diagnosis, both symptomatic and where there was suspicion, but it was not really diagnosed, and looked at a range of outcomes at different stages of pregnancy. You can begin to see already that in terms of just remaining pregnant or pregnancy continuing, there's a clear deviation on the basis of symptomatic COVID-19 infections versus the other categories in this cohort. And you see that dispersion and disaggregation a lot more clearly in terms of relative risks of adverse outcomes in the perinatal period by severity of morbidities and outcomes. So here, the two things that I want you to see are the severe neonatal morbidity index and the severe perinatal morbidity index, which is crafted on the basis of a range of outcomes that you see here, which every neonatologist would recognize. And we also then said, irrespective of what morbidity they had, did they require hospitalization in an intensive care unit? So NICU stay for at least a week or more was one outcome. And as you can see, if you have COVID-19 in both the mother and newborn baby, let's say representing a severity of infection, or just in the mother, but the baby was test negative, you see a very clear gradient of severity of complications that suggests that this is not an innocuous and benign infection in pregnancy. And this is also quite clearly seen in the context of maternal outcomes as well, and the relationship with various symptomatology complex in COVID-19 infections. For example, if you had fever, diarrhea, vomiting, or shortness of breath, you can see a very clear gradient in terms of adverse outcomes in the mother, adverse outcomes in the newborn, and in the perinatal period. And the reason why we did this is that this is the reality in most low and middle income settings, that you do not necessarily have laboratory confirmation. You may have to go with clinical symptomatology and what's wrong with the mother. Quite importantly, the link between COVID-19 infection and preeclampsia, eclampsia, or HELP syndrome is very important to underscore. And this may help us also understand what may be the pathogenesis of preeclampsia in some of these settings. However, notwithstanding all of this and the relationship of COVID-19 infections and adverse outcomes in a proportion of people, the bottom line by and large is that this is not something that requires any change in evidence-based practice. So with UNICEF, we put this policy brief out earlier on this year, titled First Do No Harm. So in your practices, such as I've just told you, with just delivering mothers by cesarean section just because they're COVID positive, is not evidence-based practice. So the policy brief very clearly underscored, and it has remained true to date, that there is an increased risk of adverse outcomes in the mother. So they do require close look, and there may be an excess risk of adverse perinatal and newborn outcomes, but absolutely no reason to separate the mother and newborn, and absolutely no reason to stop breastfeeding. I think the evidence now is very clearly in support of cohorting mothers and babies together, and not even the draconian early measures that were instituted in the first several months after COVID became recognized as a problem in pregnancy, with all kinds of PPE and separation of the mother and baby. We've also been able to underscore that the vast majority of these mother-baby dyads do reasonably well. And although there is an increased risk, you ought to be able to clinically recognize that on the basis of presentation. And several recommendations were made in this policy brief on what health workers needed to be trained in recognition of danger signs, and including COVID-19 as part of their differential diagnosis of neonatal sepsis and other issues. What about older children and direct effects of COVID-19? So here is the summary of data that we have to date from a large WHO compilation of what's been reported to it. And as you can see, the very large number of 91 million cases that have been reported to WHO. So interestingly, in terms of cases, you see, predictably, there are a large number of cases in the elderly. The bulk appears to be between the ages of 20 and 50, just by, population pyramids. Right? Pretty significant proportion of cases in pediatric age groups. You take under 5s, 5 to 10, 10 to 14, 15 to 19, the traditional 4 groupings. You see this very clear gradient with risk of, or you can say, infections increasing as you reach adolescence. Mortality or case fatality, on the other hand, is fairly rare in this age group. In this WHO compilation, it appears to be less than 1%. And although there is no clear gender difference in incidence or in disease distribution per se, you see a gender difference in terms of adverse outcomes with higher mortality amongst men. And that is something that we as yet do not have a good explanation for, other than the biological risk that you typically have early in life, but it has never been shown to be the case throughout a life for infectious disease. So this slide summarizes, it's a complex slide, but I'll take you through this. The blue are the incident data in terms of number of cases, and this summarizes the pediatric cases worldwide as a proportion of global cases. And on the right in orange are the proportion of deaths in this respective population. So as you can see, of course, there is a gradient. And as the proportion of infections increases in adolescence, as a proportion of global infections, you also see a creeping up of proportion of global deaths. So it's a threefold difference between children under 5 and adolescents who have COVID-19 infection. And I will show that these gradients are steeper once you come to low and middle income settings. But there's been a lot of interest in terms of the global distribution of deaths over time because of the overt effects of the Delta virus infections in recent months in various parts of the world. But there's no clear signal that overall, apart from this little flick that you see at the end, that there has been a massive upsurge of mortality, just like we saw in the early stage of COVID-19, when we did not have the tools, technology, or the know-how in terms of how to deal with this. This is perhaps best illustrated with data from the United States. If you look at CDC data till the end of October, and you see very clearly patterns of weekly case reports of COVID-19 by age, you can clearly see that towards this latter part with the Delta upsurge in the United States, you have an upsurge of cases in pediatrics. And that is largely reflective of the fact that by that time, a significant proportion of the adult population was protected. So this is in terms of weekly case reports in children. But fortunately, this has not been associated overall with any increased excess risk of mortality or adverse outcomes in children. People are very concerned about a change in mortality with this upsurge in Delta, and that's not been the observation in many places, particularly in high-income settings. And this is a pre-publication data set from the United Kingdom, where looking at COVID-19 in over 100,000 school-age children with either alpha or delta variants. If you look at symptomatology, if you look at hospitalization, and if you look at adverse outcomes, there's no difference between delta and alpha. So good news there, that it is, of course, maybe more common, the disease spreads more readily, but there is no signal in pediatric age group of this being associated with higher case fatality. So there's been a lot of interest in understanding why COVID-19 is less severe in children. And there are obviously reasons why COVID is more of a problem in adults, and many of you know this. The senescence of immunity by age, the elderly being more at risk of adverse outcomes because of their inability to mount an immune response, and also the way some of them are cohorted in residential settings. But in pediatrics, there are speculations in this review by Zimmerman and colleagues as to the potential association with innate immunity. I mean, children are, compared to adults, an age group where they probably have much greater proportion of immunizations in that age group, particularly younger children. So they may be able to mount a better immune response overall. And there are all kinds of other theories, none proven as definitive in terms of the relationship with cellular immunity and pre-existing exposure to the infection and antibodies. So it's something, a subject of much great research as we go along, particularly in trying to understand various dimensions of COVID-19 in children. But there may be very many reasons as to why children do not have the adverse outcomes that we have in elderly. But I have been interested in this question of differential mortality from low and middle income countries from the very outset. And therefore, one question when we set off our review process was, is this entirely true globally? Now, till the middle of last year and fall, well, very little published from low and middle income settings. And therefore, in gathering that data and particularly accessing large-scale population representative reports, took a long period of time. And actually, some of that data is only just becoming available from middle and low-income settings. So we've had a series of publications on this, looking at this with UNICEF in terms of epidemiology and impact of COVID-19 infections. We had this big review on multi-inflammatory syndrome published in The Lancet. And more recently, in March, we published our systematic review of clinical characteristics and outcomes of pediatric COVID-19 infection that I am going to relate to in this particular presentation. So we looked at the global distribution and outcomes in something like 129 case series of COVID-19. And they had to be case series. They could not be focused on esoteric or severe symptomatology only. They had to represent the entire spectrum. And as you can see, although they have some series from Southeast Asia and Latin America, Africa was a big void. So as I'm continuing this work, I'm very keen to get information from Africa, from representative pediatric cohorts as to what has been the experience and outcome. And it's been very difficult to get that information. But a few things I can share with you, and I will. If you look at the overall distribution of clinical symptomatology, irrespective of distribution by high and low middle income countries, it does appear that, like what I've just told you, the symptom complex in children is mild. You have features, by and large, that are representative of any kind of viral infection or febrile illness, with even fever being not a universal phenomenon. In about a third, there wasn't a presentation with fever as a dominant manifestation. When you look at management, earlier on, things were all over the place. I mean, a lot of people treated pediatric COVID infections with antibiotics, with a lot of interventions, with even empiric steroid therapy, IVIG, etc., because of the putative risk of complications. But things settled down by and large, and these medications that you see here, antivirals, IVIG, etc., have been restricted generally to features where people were suspecting the onset of multi-inflammatory syndrome. But I do want you to see a couple of things in relation to outcomes which jump out at you when you look at the full data. Firstly, in terms of the distribution of deaths, remember the gradient that I told you that may occur between young age and adolescence. And here in our review of these hospital-based series, it's very clear that that gradient between young infants, young children, school-age children, and adolescents is pretty steep. So proportion of deaths as a reflection of pediatric COVID outcomes, much higher in adolescents. And about 60% have comorbidities, but 40% don't. So in the reported comorbidities, with the limitations that everybody may not know what comorbid condition exists, but about 60% have comorbidities, those with fatal outcomes. But this is the important slide to look at, the comparison of outcomes between low and middle income settings and high income settings. And it's very clear. It totally depends upon the health system. So if you do not have health system capacities to provide intensive care, children in low and middle income countries don't get it. So only 10% versus 26% in these hospital-based series had children in any kind of intensive or semi-intensive setting. And access to ventilation is similarly limited. And if you look at mortality case overall in these studies, it's twofold difference in mortality between low income and high income settings, 2.9 versus 5.2% in this particular analysis. And this is not including multi-inflammatory syndrome. So if you take multi-inflammatory syndrome that we reviewed and published, as I mentioned, in the Lancet earlier on, and we have recently updated this review, we had 86 case series of multi-inflammatory syndrome, largely from high-income settings, but a few that included parts of the Middle East, South Asia, one from South Africa, and two from Latin America. So we had some basis for comparison of what were the outcomes in pediatric series of multi-inflammatory syndrome. Clinical symptomatology is more varied and inclusive of things that are very reminiscent, as you know, of Kawasaki disease, with about 30 to 40% presenting with myocarditis and manifestations that relate to upper respiratory infections. Shock in about 30-35% of all of these case series overall. But also a few protein, mild manifestations, and a few diarrhea, respiratory, vomiting, conjunctivitis, etc. So nothing very sophisticated here. But when you look at laboratory abnormalities, a lot of these children, about over half, have manifestations of systemic inflammation, and you can recognize that on the basis of what is available in many of these series from the respective investigation panel that was implemented. What about outcomes? So here is the same graphic that I showed you before, but this time for multi-inflammatory syndrome. So these 550 children from 21 studies where we are able to compare outcomes between high and low middle income settings. Again, you see some differentials in healthcare within the health system, but it's not as dramatic as you saw overall. So about half of children in LMICs were admitted to ICU, and not everybody in high income settings was admitted to ICU either. But it looks like about a fifth did receive ventilation, but the case fatality differential is quite remarkable. It's about fourfold. So it is not an innocuous infection depending upon the health systems. And that's why when you have a Delta virus outbreak in India, for example, in the midst of hospitals not having beds or not having oxygen or not having delivery system, then outcomes will be adverse. And that's what is reflected in the global pediatric data for COVID-19 also, that depending upon the strengths or weaknesses of the health system, you will have differential outcomes. So let me try and summarize what we know on this so far. And a lot of this is also in the WHO summary that's available on this and from our systematic reviews that I've mentioned to you. So firstly, it's an infrequent disease, but not an absent disease in children compared to adults, but there is a gradient, clear gradient. And by the time you get to adolescence, risk of infections and outcomes become comparable to that of young adults, particularly for older adolescents. These adverse outcomes are more common in children with comorbidities, although we recognize that comorbidities may not be diagnosed in every instance, just given the silent nature of some of those. MISC remains a minority. It's a rarity. It is not the rampant kind of global pandemic of multi-inflammatory syndrome that people feared last year. And particularly with Delta, we thought we would see an upsurge, but there hasn't been an upsurge. But the worrying thing here is I can't tell you on the basis of my read of the literature if you could predict which child is going to potentially get missed from either early symptomatic or asymptomatic infection. So we don't have a good handle on this. And this is something that one needs to recognize. Adverse effects, severe disease as well as mortality are significantly higher in low middle income countries than high income settings. It's a reflection of differentials in health systems. We are undertaking a global systematic review of long COVID in children. Data on some of this is just beginning to emerge. So I'm not discounting that this may be an issue in certain circumstances. I've already spoken about Delta and complication rates. So let me now turn to what I think is the bigger challenge for pediatricians worldwide, is to look at the differences by direct and indirect effects. I've spoken plenty about direct effects, so I will not spend more time on it. But here is work that we did with UNICEF on looking at this in detail in a geography that I know well, which is South Asia. This was published in March, and it has been updated recently with data even including the first and second quarter of this year. So if you take the region, South Asia, and these 6 countries that I'm summarizing here, they've all had similar patterns to what was a global upsurge, maybe a little delayed temporarily in time and reflective of the severity of variants as they emerge everywhere. But I want to see one country in particular. It's not an innocuous or an infection that only occurs in dysfunctional health systems. Sri Lanka has probably got case mortality rates in children and survival rates comparable to any developed country. Phenomenal investment in primary care. But if you look at how Delta affected Sri Lanka also, they had a massive upsurge at population level of COVID-19 and also associated with excess mortality at a population base. So absolutely not an innocuous illness at all. At a very early stage of the pandemic, people didn't know what was going to happen. And therefore, a lot of measures were put in place, what we call COVID mitigation strategies. Lockdowns, school closures, business closures, curfews, travel bans, and all of that put together has an index called stringency index. And the takeaway message from here is that in all of South Asia, like the rest of the world, by pretty much about March last year, everything had closed down. And that remained the case for several months. But you will notice that the region has varied enormously in terms of reopening its workplaces and sadly, the schools. So if you look at how these 6 countries have fared in terms of school closures, there was a half-hearted attempt at closing schools. I just want you to focus on this geography that we are talking about, South Asia in the middle here. And then by pretty much May last year, everything had closed. But the region took its time to reopen. And as you can see from these color gradients, even when they reopened, they closed again very quickly. And as we speak today, only a fraction of schools have opened in some parts of the country. Pakistan is open, but still in many other geographies, schools are as yet not open. And these economic measures, lockdowns, school closures, all have had an enormous impact. If you were to imagine how they could impact children, there are a whole range of ways in which children can be impacted, as well as their mothers. So I'm not going to talk about health services coverage because you've seen it, but I'll show you some data. But what we are most concerned about is the impact of the reduced economic activity, increase in poverty, and disruption in education, and what happens to school dropouts. And in particular, we have been very focused on what happens to young girls in many of these settings who are out of school for 6 months, a year, more, now almost coming up to 2 years. And for a 16, 17, 18-year-old to drop out of school in many of those circumstances, you can well imagine what happens. They're typically either married off or the families have to take time off just to look after them. So this is not insubstantial, and this has had consequences. But let's very quickly first see if the disruption was real and did it affect indirectly health services. So here is actual data from district health information systems from all countries of South Asia, collected through the good offices of UNICEF, on what happened to family planning, to antenatal care, to facility births, to vaccinations, and treatment for pneumonia and malnutrition, as an example. And you don't have to be a rocket scientist to work out that the disruption was massive, and that until Q2 2020, up to 30–40%. But the take-home message from here is that even now, today, in Q2 2021, many of the things have still not returned to baseline. So we are still facing disruptions in terms of people not coming to health services, particularly children with chronic diseases, and also people not seeking care in the traditional health system the way they were before. And our modeled estimations in terms of impact on child mortality of these closures and these lack of access to services is quite substantial. I had mentioned earlier on the risk of adverse outcome due to COVID infection on stillbirths. Actually, if you don't have antenatal care and you don't have services to the mothers, you can have excess risk of stillbirths, and that is what we see over here. So it's been a double whammy in some ways, with excess child mortality, maternal mortality, and unwanted pregnancies that I will talk about in a minute. The more important thing to note is that over 400 million school children in South Asia have been out of school since March 2020. And irrespective of what people tell you, internet-based education, remote learning, that's only a benefit to the rich and to those who are living in urban centers with adequate data access and support. Poor children in rural populations have really not had access to this. And our estimation is that, although it says 1 in 3, but I believe it's over half of all children have not been reached by remote learning. And some recent data from India suggests that the estimated loss of learning time is at least 2 years and more. And if you go by the evidence from Ebola, this is not something that children catch up readily. My major worry from day one, and my advocacy with UNESCO and others had been, for God's sakes, don't close kindergartens or don't close the preschool system. Why? Because that time window is critical to development. And it's particularly critical because that opportunity will not come back. So our estimations overall, in terms of mean years of education lost because of COVID, is actually much more than 2 years. We believe that this will overall impact this population, not to be too nihilistic, quite substantially, unless some remedial measures were put in place. And the numbers are quite frightening. The one thing that I will show you as I close this part of the indirect effects is our estimations based on the LifeSafe tool model of what would have happened in girls if they dropped out of school. And the numbers, as I said, is quite large, close to around 5 million girls. So if they have early onset of pregnancy because they are married off or otherwise, the impact on their own nutrition, the impact on adverse neonatal outcomes, on low birth weight and stunting are pretty massive. And if you tally it all together, this becomes an impossible figure, far more than what people would have spent in trying to keep schools open. So we've unfortunately had a situation which I hope will never arise again, of a knee-jerk response to a pandemic by closing schools because it was easy to do so, and because of risks of something that there was no evidence in the literature for. Quite earlier on in the pandemic, UNICEF had come out with a statement in March 2020 that I show everybody because I think it was so prescient. What they said in that opening statement of that report was that children may not be the face of this pandemic, but they risk being amongst its biggest victims because their lives are changed in profound ways. And because of the experience at UNICEF, they were saying this on the basis of what they had observed with other outbreaks and Ebola in Africa. But it's turned out to be true. And I believe not only just by closure of schools, but the mental health impact, this has been a universal problem worldwide. And it's been such a divisive problem in terms of keeping schools open, particularly here in North America, not as much in Canada, hopefully, but in the United States, this has been a politically divisive issue for reasons that are beyond me, because the evidence around this is pretty clear on the basis of the global collation. So what is that evidence? What is the evidence in terms of school transmission and risks? So this is another systematic review that my group published a few months ago. It was based on a review of the literature from regional and national prevalence studies, 31 community or family cluster contact tracing studies, and 30 school or daycare contact tracing studies. And admittedly, at the early part of the pandemic, nobody was setting research studies to look at what happens when you keep schools open or keep schools closed. So a lot of these are quasi-experimental evaluations. But now we have data emerging from large cohorts where we are able to look at some of this, and particularly with the Delta variant upsurge. And I think the findings that I will summarize with you now stand largely true. So the first thing is that the risk of infection is much lower in younger children. And as I've already told you, adolescents have, and this is not just from the global review, this is from the school transmission work. So younger children, less likelihood to get overt infection with COVID. And the risk is lowest in daycare settings. And there is a gradient as you go from daycare to primary to high school. And by the time you reach high school and adolescence, as I've said already, the risks become comparable to what you have in young adults. When you look at what is the impact of being infected in school on infecting family members at home or on community transmission, this has been a big issue. And the only way to evaluate that would have been to look at studies where schools were either open or partially open at the time when the transmission studies were being done and contact tracing was being done overall, or where schools were closed and you were measuring this. And we have a large number of studies where this has been done across the world, including in Asia. And the take home from this is that it doesn't matter to overall burden if schools are open or closed. So the global evidence on this is where people have kept schools open, the Israels of the world or other countries in Southeast Asia. It really doesn't make any difference to community transmission. So there is no access risk to family transmission by keeping schools open. So why does it matter? Because there has been this massive debate worldwide on whether the evidence on infections, risks, and indirect effects in school-age children are those that lead to some decisions in terms of intervention and vaccination. So many places that have kept schools open over the last year and a half have tried to put measures in place like masking, like cohorting, like reducing the number of children, shift system, et cetera, and they all have their limitations. And the reason why this has been a debate is largely on vaccine equity. There is not enough vaccine to go around the world. So when we looked at this recently, and these are data as of 6th of November, around 7.5 billion vaccine doses have been administered worldwide. But only 400 and some million doses have been shipped by COVAX to low and middle income countries, 144 countries. And there are several where either vaccinations have not even started, but they have not been able to institute adequate vaccination. So compared to North America, where we are looking at 70–80% of the population having received at least one dose or more of COVID-19 vaccine, you're dealing with a situation where our current estimates are less than 5% of people in low-income settings. And they have, even with vaccine supplies, even with the extra money, no hope of getting that much higher. Why? Because the COVAX facility is artificially pegged at only guaranteeing vaccination to 20% of the population. And you can imagine what happens in a low middle income setting when you get a vaccine in and you only have enough to give 20%. Who do you think gets it? It's the 20% who are privileged. I mean, the parliamentarians and the politicians are first in queue to get that vaccine. And therefore, we already created that situation with providing a very limited dose of vaccine to ministries of health and other program people have said, now we are not concerned with how you do it. That's all you've got. Go and vaccinate your population. They're not going to be able to do that. Who's going to be able to guarantee a vaccination for its population at about $30 a pop? This is just ridiculous. So I think we set it up in such a manner as a global community, whereby we made it very difficult for them to adequately vaccinate their population. So the considerations that we have for childhood vaccinations in low middle income countries are several. We have to balance whether we vaccinate children or otherwise against the impact of school closures. And in many countries, the reason why they kept school closed, despite the evidence, was because they were worried about infections in their children. Not just the risk of infection from children to their families, the parents were worried about infection risk in their children. And the need for testing and what have you. I mean, I have twin grandchildren who live in Boston, and they have been tested at least 9 times in the last 6 to 8 months since they started going to school, just because of the protocol for risk and all of that. And none of them were positive. So you know, children will have infections. It's just that we put those systems in place that makes it very difficult to adequately have schools functioning. And there are, of course, as I said, consequences of school closures that have to be balanced against any alternative. And they are very serious in terms of mental health consequences for many. There are additional considerations that I will mention. Just the practicality of mitigation measures in schools. Children will be children. If you imagine that a child will be able to follow a protocol for masking and protocol for other things, that's going to be very difficult. And it is, even we know from high schools and we know from adolescents that compliance with what is standard mitigation strategies is very difficult. And nobody monitors this in LMICs. There are different family demographics, irrespective of what I've told you overall. In many low and middle income settings, people are concerned about children bringing the virus home to elderly, where elderly typically live with their families. And comorbidities, for which there is a current guidance from WHO on vaccinating children with comorbidities, that are very difficult to detect and diagnose. So the World Health Organization's position very firmly that children should not be vaccinated, they do not support vaccination, I think is a bit harsh, and I've told them so. I think countries ought to be given that possibility that they can make that decision themselves based on what is a risk-benefit assessment. But I believe the evidence now in terms of childhood vaccination strategies for children is pretty clear. We have effective vaccinations, all with efficacy rates above 90%, most of the studies from high-income settings. And if we do not vaccinate children in low-income settings or low and middle-income settings, we're not going to get that evidence up. So I think from just a global equity perspective, we need to consider school vaccination strategies. And, you know, irrespective of what WHO says, a number of countries have already begun doing this. Costa Rica, in this particular hemisphere, has already decided to vaccinate all of its school-age children and adolescents. And in Pakistan, the government has decided to vaccinate school-age children and adolescents. The decision on vaccinating children is currently based on just supply availability. But it's not based on the principles of universal health coverage, where children have the same rights to interventions as adults. And I think we need to relook at that in some practical manner. So let me close, ladies and gentlemen, by giving you a sense of my assessment overall of COVID-19 globally. It is a relatively mild infection in children, but the indirect effects in women and children overall may be far worse than direct effects. Studies from community and household clusters show that there is lower susceptibility in children, but in adolescents, you have comparable risk of infection. And that's why several sero studies now show prevalence rates of antibodies in adolescents about the same as adults. We need mitigation measures in school-age children pretty urgently. All of the data on vaccinations that I've shared with you is from high-income settings. We have very little in terms of innovations that may work, such as open-air schooling, such as, for example, shift systems in schools in low and middle-income settings, and how to address this issue from a public health and education policy making. But I think overall, my position is that we do need to vaccinate children as part of vaccinating populations at large. We should start with adolescents, as has been the case here, but we should very rapidly move to school-age children to keep them in school. And when there is enough supply of vaccines, potentially also consider under 5 as the global evidence on this emerges. So I'd like to thank you for your attention, and I'll be very happy to answer questions if there are any. Thank you.
Okay, thank you so much, Dr. Bhutta. That was a wealth of information. So many things to think about and you went through it in such an interesting and informative way. So thank you very much for presenting that to us. We have a number of participants here. I'm going to open it up to questions. We have about 10 minutes for questions. So if you do have a question for Dr. Bhutta or a comment, please, there's lots of hand claps. I don't know if you can see that, Dr. Bhutta, but please either raise your hand or you can just unmute yourself and start speaking. And while we're waiting for everyone, there were so many things that I wish I could have just stopped you and asked as you were presenting. But one thing that struck me, I wasn't actually aware that WHO was not supportive of vaccinations for children. I presume that's it's a matter of need to vaccinate the adults first. But I wonder if you could speak a little bit more about that, because that was very interesting and surprising to me.
Yeah, I mean, WHO's had a dilemma because, they said the same for boosters, right? And it is very clear it's now a 3-dose vaccine. This is not a booster. The vaccine is a 3-dose vaccine in many places, with the senescence of immunity that we know. So I think WHO, frankly, even though I work very closely with them, at times takes a decision on the basis of what it thinks is the right thing to do. And they then stick with that decision, irrespective of changing evidence. It takes a long time once you have taken a decision, a policy decision, to change it. So just like I think they've been wrong on boosters because the science and evidence was there, but they were probably right to say, well, rather than give boosters to all in high income settings, let's vaccinate the world. They've been dead right on that. But I think the phraseology on this could have been a little different, because a lot of people understood that to say, well, you don't need boosters. That's not the case. Similarly here on WHO's guidance, the guidance was vaccinate adults first, but the way they phrased it said, we don't think children are a priority. And I think it totally depends on the context. Mm-hmm. So if in a given country, people are concerned that they are not going to be able to open schools without vaccinating children, and they have the vaccine to do it, they have the spare vaccine to make it happen, then I think that decision ought to be the country's decision. So they could have phrased it in a way to say, evaluate the context and situation, and if you are able to provide adequate vaccination to adults and have the ability to vaccinate children, please do so. So that people did not turn around and say, well, it's not a recommended vaccine in children because of already in the anti-vaxxers lobby, the whole issue around vaccinating children was, you don't know enough, you haven't had long-term studies. Why are you vaccinating children? So many people believe that in North America. And while there is some validity that you've not had long-term studies, the pandemic's only been there for 18, 19 months. But that doesn't mean you don't do anything.
Yeah.
Let me see if there are any questions in the chat. Well, I think Canada has been fortunate in that the Canadian Pediatric Society and Canadian pediatricians have been pretty united in terms of what they need to do. It's been far less divisive than our southern neighbors. Yes. But I think also as vaccine supplies improve and people get more confidence in terms of vaccination at population level, there is a global responsibility. The reason I make this presentation is that we are not going to be able to control this pandemic just by narrowly focusing on our own geography. The world is going to open. And as the world opens, you've got to look at this as a global issue where high income, middle income, low income countries stand together.
Absolutely true. Absolutely. It's where the advocacy becomes so important. not just within our own borders, but globally.
Yeah, and it's like any other infectious disease. You're not going to be able to contain a virus within a particular geographic border, particularly something like this.
We have a, I don't know if it's a question or a comment from Dr. Anne Famui. Anne? Infectious disease and immunology.
Oh, hi. Can you hear me?
Yes.
Hi, I just want to thank you for that great talk and overview, and then providing a very balanced and nuanced, I guess, presentation of a complex issue as well. So I just want, I guess it's a comment as well. Just, you know, we're preparing to roll out, you know, pediatric vaccines to the 5 to 11 and like soon, I would say. I'm hearing it elicits a lot of, I think, emotions from both caregivers, but also healthcare providers. And I think I would, you know, continue what you've been presenting, is that it's not as simple. So you can't just look at the direct effects for the individual. You have to see it broadly. And I completely agree with your statement that probably we will find out that one of the biggest victims of this pandemic are the children, and the indirect effects, you cannot downplay them. And so I would urge, I think, our community to, you know, you know, develop those relationships with families and parents, because really it's vaccine confidence and trust that are going to be the most important things. And it's normal for everyone to have questions, and maybe even some providers might have hesitations themselves, but to be able to provide this kind of balanced view or in terms of the counseling, because I've heard some healthcare providers share their hesitations with families, which you know is just very, very tricky in this context, because families will you know, take that to heart. Or so same with this message that the World Health Organization is not supportive of children vaccination. This might be interpreted in a different way, and we have to take it into our current context as well. So again, thank you again for your presentation and for all your work.
Well, thank you for those comments. And, you know, I am somewhat invested in this also as a grandfather. I mean, children have been leading, irrespective of what people think, a very problematic life the last couple of years. Virtually no social contact, almost no birthdays, no events that you consider as part of normal growing up. And the periods of absences from school where people are scared with even the mildest sniffles is tantamount to actually being out of school. I mean, there is data now to suggest, of course, that our current protocols for this are virtually bordering on the paranoid. So if you want to get to some level of normalcy, just like in adults, you have to have a vaccination strategy. Just a masking strategy is not going to be enough. And we would not have reopened, and we wouldn't be able to reopen if we did not have vaccination strategies. So I think as the evidence emerges, I think absolutely we need to make the benefit of vaccination available to our children. And yes, we will have the evidence as it goes along, and people are very carefully looking at the risk balance equation here. But the vaccine appears safe. And I say this with great confidence, because nowhere in the history of mankind have you had so many billions of vaccines given at scale with so many eyes focused on it. So it appears to be safe. And it is actually, I think the technology, particularly mRNA technology, is a groundbreaking technology, because you will have this emerge from other vaccines very soon.
Okay, so we have a question in the chat, and then a question from Dr. Huey. So I'm going to give you the question in the chat first. This is from Dr. Sarah Reed, an emerge physician. Can you comment on the timing of boosters in high-income countries with respect to global equity?
Yeah, well, I mean, you know, the equity question I've already addressed. I do think boosters will be needed across the world, because for certain vaccines, this is even more important than the mRNA vaccines. For example, all the vector-related vaccines, the inactivated vaccines, we know very clearly that the only way people are immune is if you have a mild infection and a vaccination. So the immunity wanes. And if it wanes, as we are beginning to see, then you have to boost. So nobody will claim flu vaccines to be evidence-based if you only gave them in one season and expected it to protect you for several. So I think the question on boosters has to be answered on a scientific manner. So countries that are vaccinating their populations, and they know that their population will not be protected beyond a year or so, will have to take a decision to protect them. So I think for WHO to say don't give boosters has to have some scientific basis, and it doesn't have scientific basis right now. So what we should be doing is producing enough vaccine to provide everybody adequate protection rather than leave large sections of the population unprotected. So I just had my COVID booster yesterday, even though I thought that I would be still reasonably protected. But it is a 3-dose vaccine. I mean, very clear evidence on that emerging from large real-life studies. Let's take Dr. Huey's question.
Okay, Dr. Huey.
Yes, great. Thank you. So excellent presentation. Congratulations on you and your team for this great work that you've been doing, and specifically also for the advocacy. So my question, apologies about the background noise. My question is around the issue of health equity again, and on advocacy. So take, for example, you highlighted Africa. There's a lot of inequity in Africa. Take, for example, there's many countries in Africa where there's less than 5% of the population has been vaccinated, where, in high-income countries where 70 to 80%, as you quoted. But what about the issue about procurement and ordering? Like, take, for example, Canada ordered the most per population in the world. We ordered 5 times the amount of vaccine required than we had per population. And so, yes, there is the COVAX distribution system and the ability to, but once it gets there, but if you've already ordered it up, then it can't get to COVAX unless we are kind of generously donating the vaccine.
Actually, Canada also took from COVAX. So that's the irony of it. No, I completely agree with you. I think there is a responsibility on the part of high-income countries that have vaccine surpluses is not to maintain a massive surplus. I'm not saying Canada shouldn't have a buffer, but that buffer has to be reasonable and the rest should be given. This is a finite vaccine. At the moment, all the donations of vaccines that are taking place, you hear every day in North America, this and that, are of vaccines that will expire in the next 3 months. So they're giving away vaccines that are not going to be able to utilize. I think that equation should change and surpluses should be diminished by vaccinating everybody. But, these are utopian considerations. Very rarely does this happen with countries putting their own interests on the back burners and doing things that are for global solidarity. I think it should happen, but something else should happen. So 2-3 things I hope will happen very fast. So first is the whole intellectual property rights issue, the TRIPS thing. Just like HIV, we would not have been able to, PEPFAR and the 3x5 would have failed had countries not decided, we're not going to believe in patents, we believe this is the life-saving drug, so we want generics and we want these at low cost. So that needs to happen for these vaccines also. The technology transfer for the vector vaccines has already been done to India. There is no reason why the mRNA vaccine cannot be produced in Africa for Africa, in Asia for Asia. And that needs to happen very fast. So we have a position paper on this coming out in the Bulletin WHO very soon where we make that case. And I think that can be fast-tracked very rapidly. So that's one on procurement. Secondly, I do think we need to make more resources and money available to countries to do this. And whether it's debt swaps, whether it is other measures in terms of proportion of ODA that goes into this, this is a global priority to protect populations. Third, there is something very interesting, Dr. Huey, emerging also, which we have to study and understand a little bit. Many of the data that we have on potential cases, the IHME map, for example, from Africa and Asia, is discordant with the situation on the ground. So we do not have, from any available public health measure, anywhere near the case fatality and mortality of COVID in Africa that people predicted. I work in conflict settings and emergency settings substantially, and I know of no conflict or emergency setting where hospitals are full with COVID cases or graveyards are overflowing. So there is something very interesting going on also in LMICs that we have to understand, which is an epidemiological pattern of COVID, which is outstripping what we think we know from high income settings. So we've just finished a sero survey in urban and rural Pakistan, and the prevalence of antibodies, neutralizing antibodies, 85% across age groups. And so therefore something is happening that we need to understand a little better. India saw a dramatic drop in COVID-19, Delta, post-Delta, far faster than their vaccination rollout. It came down to levels of less than 1% positivity far earlier than what would have happened with vaccinations. There is no other explanation for it than herd immunity. And I don't understand why herd immunity patterns should differ in different parts of the world. But I do think that this is an epidemiological conundrum that we have to resolve very quickly, because it has such huge implications for exactly what you're asking about. Decisions to vaccinate or not to vaccinate, who to vaccinate, and how to do it. So thank you.
Wow. Okay, well, we're out of time, but you just dropped something major on us at the end there. It's like the end of a series, and you're like, keeping us warm till the next season opens up. It's a big teaser for us. That's really interesting information. Thank you so much for all of your work in this area and for sharing it with us today at Grand Rounds.
Thank you
So much.
Pleasure. Bye-bye.
Okay, bye-bye, everyone.
Thank you. Bye-bye.